My dear students, welcome. On a previous session, we were discussing antiretroviral therapy. And on that session, we discussed the NRTIs, nucleoside and nucleotide reverse transcriptase inhibitors, and NNRTIs, that's non-nucleoside reverse transcriptase inhibitors. And we were just saying about the protease inhibitors. So we continue on this session with the discussion of the protease inhibitors. And the latest strategy in the management of the HIV disease is to use two protease inhibitors. So as we say, we always use one NRTI, one NNRTI for example, and one PI. So you already have one drug from each of the groups, one NRTI, one NNRTI, one PI. In addition to this, we use one more PI, and that's one more PI is ritonavir. And this is called low dose boosted ritonavir therapy. So you are giving your usual treatment. You may give one NRTI, one NNRTI, one PI, or in few cases, you might use two NRTIs and one PI. Whatever it is, those are your basic three drugs. In addition to this, add one more drug, and that's always ritonavir. And this is called low dose boosted ritonavir therapy. So let's know why this low dose boosted ritonavir therapy is given. As you know, ritonavir is a protease inhibitor, and it is a potent inhibitor of the cytochrome P450 enzyme system. What does this mean? This means ritonavir is going to inhibit the metabolism of other drugs. And amongst these other drugs, there will be also that one protease inhibitor which you are using. So ritonavir is going to inhibit the breakdown of that protease inhibitor. And this is going to produce beneficial effect to the patient. So this is going to boost the concentration of the protease inhibitor. And this is why the term is very apt. We are not giving ritonavir in a large dose. That's not required for this purpose. Use it in a small dose. So we call it low dose boosted ritonavir therapy. I hope my point is clear to you. And I'm taking you to the next slide where various combinations of one protease inhibitor which you are going to use in your therapy with ritonavir have been shown. Yes, it's a long table, but we can have a look at the names and slowly you can start remembering the names. And there's no need to remember the whole thing because ritonavir is there everywhere as you see on this slide with each of the drugs. What are the drugs? The protease inhibitors is fosrampirenavir, lopinavir, atazanavir, darunavir, tipranavir, indinavir, saquinavir, ampirenavir, and nelfinavir. We got a bunch of protease inhibitors, and with each of the protease inhibitors 100 milligrams, usually 100 milligrams of ritonavir is going to be combined, and that's that low dose of ritonavir which is going to boost or potentiate the other protease inhibitor. On this slide, exactly in the middle, there are two combinations shown. I want you to remember these two combinations because these are the latest drugs, the latest protease inhibitors. One is called darunavir and the second one is called tipranavir, and they will be combined with ritonavir small dose. Darunavir and tipranavir. Why we want to remember? Number one, these are the latest protease inhibitors. Number two, when are we going to use them? We are going to use them for multi-drug resistant cases, and this is why I want you to remember these two names from the protease inhibitors, darunavir and tipranavir, to be used for multi-drug resistant cases. Let's discuss the protease inhibitors, the PIs, in details now. And remember a few things, important things about PIs. It's easy to remember because all of them together produce certain adverse effects. And when this happens, we could remember that it applies to the whole of the group. The first important thing protease inhibitors produce is they produce glucose intolerance and insulin resistance. And if your patient is especially diabetic, his blood sugar can go on increasing, what we call hyperglycemia. In other words, these drugs are diabetogenic or they produce precipitation of diabetes mellitus. That's first one, that's about the glucose metabolism. Second, common adverse effect to all protease inhibitors is disorder of the lipid metabolism. So number one, glucose, and second one, the lipids. And what happens as far as lipid metabolism is concerned? There is maldistribution or redistribution of the fat. And the fat gets deposited at abnormal sites inside the body, and this is why you get what is called central adiposity. The fat gets deposited in the center of the body, and you get those typical adverse effects or symptoms which you get on long-term corticosteroid therapy, or how the patient with Cushing's looks. That's moon face, buffalo hump. I hope you remember all this. And you see on this slide, I've drawn a small picture for you, and it's called lemon stick appearance. The fat is getting deposited in the center of the body. That's called lemon stick appearance. Next disorder of lipid metabolism could be hyperlipidemia, and this could be hypertriglyceridemia, or it could be the increase in the total serum cholesterol. That's hypercholesterolemia. So we heard two bad things about protease inhibitors as far as our patient is concerned. Number one, the glucose metabolism disturbances, and number two, the disturbances of the lipid metabolism. The minor adverse effects, they do produce nausea, vomiting, diarrhea, and paresthesias, and I hope you are going to remember they are inhibitors of the cytochrome P450 enzyme system. We know this fact, and we are making advantage of this fact by using low dose ritonavir therapy along with the other PIs, so that the other PIs could be potentiated. Now we are doing some of the individual protease inhibitors to remember a peculiar adverse effect for these drugs, for each of the drugs. Okay, the first one, indinavir. This indinavir is known to precipitate nephrolithiasis. So it's formation of the renal stones. And if we want to avoid this, the patient should have large amount of water intake. So indinavir, nephrolithiasis. Second one is ritonavir. What is to be remembered about ritonavir is it produces a very bitter taste sensation in the mouth. You go to the HIV patients who are receiving ritonavir, you talk to the patients, you'll realize there is a bitter taste sensation. There is loss of the usual pleasurable taste sensation in your oral cavity. And naturally, the doctors and the sisters in these wards, they are carrying chocolates with them to give to the patients who are on ritonavir just to change the taste. So this chocolate is going to make you remember of the bitter taste with ritonavir. Next, saquinavir, nelfinavir, and amprenovir. These three drugs have got some common properties, common adverse effects. And what is common about them? They lead to hypersensitivity reactions, skin rashes, and Stevens-Johnson syndrome is especially known with saquinavir. So hypersensitivity reactions, saquinavir, nelfinavir, amprenovir, and Stevens-Johnson syndrome, especially important for saquinavir. The next drug in the group is fosamamprenavir, and this fosamamprenavir is known to precipitate the hepatic insufficiency. And most important, no dosage adjustment required in patients with renal insufficiency. You see this last line on the slide, and I have underlined it, and try to remember what we did on the module of the NRTIs, the nucleoside reverse transcriptase inhibitors. It may be zidovudine, lamivudine, stavudine, etc. For every drug we said dosage adjustment in renal insufficiency. Dosage adjustment in renal insufficiency. Because the elimination is proportional to the glomerular filtration rate. You can't help this. You have to take precaution if the patient suffers from renal damage. So I said this was the characteristic of NRTIs. As far as renal insufficiency is concerned, PIs, that's protease inhibitors, are better, and there is no dosage adjustment required in renal insufficiency. But coming to the individual adverse effects, once again, indinavir, nephrolithiasis, ritonavir, bitter taste sensation in the mouth, saquinavir, rash and Stevens-Johnson syndrome, and fosamamprenavir, hepatic insufficiency. Such facts are going to be useful to you when you are tested on your objective questions. Protease inhibitors. What's the mechanism of action? The mechanism of action is already there in the name of the group, that they are protease inhibitors. They are going to inhibit the aspartate protease enzyme taking part in the late protein synthesis. And this aspartate protease is encoded by POL gene the pole gene. Cleavage of the precursor polypeptides to form proteins of the mature virus code. This is an important step, and this is going to form the mature virions of the HIV, and aspartate protease enzyme is going to help in this. So protease inhibitors inhibit this enzyme, and then there will be difficulty in the formation of proteins of the mature virus core. The enzyme to which the protease inhibitors bind is aspartate protease, which is a dipeptide structure. Important thing to remember is this type of structure is not seen in the mammalian proteins. That's very important. It means only this virus has got this kind of a dipeptide structure in the aspartate protease enzyme. Human beings and mammals, they don't have this type of dipeptide structure in their protein. This is good or bad? Yeah, it's good. It's good, and then this is why the protease inhibitors are not going to produce a similar kind of action in human beings. This is why, if you just notice, the nucleoside reverse transcriptase inhibitors, they are producing much adverse effects by interfering with the human system. For example, bone marrow suppression. When you say bone marrow suppression, they are inhibiting human bone marrow. The other adverse effects also are related to this. But when you come to protease inhibitors, we don't have those kind of adverse effects. Here the adverse effects are like glucose intolerance, precipitation of diabetes mellitus, or say redistribution of fat, or hyperlipidemia, disturbance of lipid metabolism. But we're not talking about bone marrow suppression, thrombocytopenia, leukopenia. This is missing with protease inhibitors. And one of the reasons could be the mammalian protein structure does not have the similar kind of structure, that's dipeptide structure. How resistance is developed to the protease inhibitors? Resistance is developed by specific point mutations in POL gene. I want you to remember this. Sometimes this can be helpful for the objective question. What is the name of the gene through which this specific point mutation takes place? Is there any partial cross resistance between the PIs? Yes, there is a partial cross resistance. So sometimes it could happen you tried one PI and the patient is not responding, and the patient may not respond to the other protease inhibitors. So I think that was fairly detailed discussion on the protease inhibitors. Now let's address the agents which I call new agents. They were spread out in between in the classification of the antiretroviral drugs, but these are the newer agents, so I kept them aside and we are discussing them here. What are these? The first group is entry inhibitors or fusion inhibitors, and you can see on the slide, the title of the slide. One is enfuvertide, which acts through the GP41, and the second one is maraviroc, which is a CCR5 antagonist. Fusion inhibitor is enfuvertide. This binds to the GP41 subunit of the viral envelope glycoprotein, and it blocks the viral fusion to the cell membrane. So we are calling it fusion inhibitor. Is not going to allow the virus to get fused with the cell membrane. It inhibits fusion of HIV1 to the CD4 cells, and the gene which is encoding this is called ENV gene. The name is derived from the name of the drug, enfuvertide. So ENV gene. When to use enfuvertide? This is reserved for persistent HIV replication despite ongoing therapy. It means this is a reserved drug. That's why I am discussing it last. So fusion inhibitor, enfuvertide. The second drug is CCR5 antagonist or maraviroc. It blocks the CCR5 co-receptor. What is CCR5? It's chemokine receptor 5, and this receptor works hand in hand with the GP41. This drug, maraviroc, a CCR5 antagonist, is also reserved for persistent HIV replication despite the ongoing therapy. The third drug we need to remember is a newer agent, is an integrase inhibitor or raltegravir. This inhibits the final step in integration of the strand transfer of the viral DNA into host DNA. So what am I saying is, when there is a strand transfer of viral DNA to the host DNA, there is an integration of the strand transfer. This is the final step. Here these drugs are going to act and inhibit it. So I am calling it integrase inhibitors. Again, you see the same line on this slide. Reserved for persistent viral replication despite ongoing therapy. Next, we discuss the prophylaxis in HIV. How to prevent the transmission of HIV. First, considering the needle stick injury, we can use AZT, that's zidovudine, plus 3TC, that's lamivudine, plus minus indinavir. This can be used. Have a look at the slide and you're going to revise the facts about the prophylaxis of the antiretroviral therapy of the HIV disease, prophylaxis of the needle stick injury. Yes, we were saying about the prophylaxis, needle stick injury, AZT plus 3TC plus minus indinavir. Okay. Next, regarding pregnancy. The first way is azothioridine, AZT in full dose. The full dose of AZT will be 100 milligrams 5 times a day. This is given during trimester 2 and 3. That's roughly from 14 to 34 weeks. So give full dose 100 milligrams 5 times a day during the second trimester and third trimester. And during labor, give 2 milligrams per kilogram over a period of 1 hour by intravenous route. So she received during second, third trimester full dose, plus during labor 2 milligrams per kilogram body weight over a period of 1 hour by intravenous route. And then every hour 1 milligram per kilogram body weight. 1 milligram per kilogram body weight every hour. So this is AZT, and then you have the neonate, the baby is born. For the neonate, continue the AZT up to 6 weeks. And this has been found to decrease the transmission by 80%. The second option on this slide is nevirapine. And I hope you remember, we discussed about nevirapine. It is an NNRTI and it's useful in single dose. You could be asked on your multiple choice question, which of the following drugs is useful in single dose for prevention of HIV. Nevirapine single dose, 1 dose at the onset of delivery, that's 200 milligrams, give to the mother, just 200 milligram, 1 dose. And then 1 dose to the neonate within the first 3 days. And this dose is 2 milligrams per kilogram body weight by oral route to the neonate. So 1 dose at the onset of delivery to the mother, 1 dose to the neonate within first 3 hours of delivery, and this leads to 50 to 60% decrease in the transmission. So you can, for prophylaxis in pregnancy, we can use NRTIs, that's AZT, 3TC. You can also use DDI or D4T. You can use an NNRTI, that is nevirapine, that's in single dose. And sometimes you can also use protease inhibitor like lopinavir or ritonavir, or from indinavir, saquinavir, nelfinavir, ritonavir, etc. So that's about the prophylaxis of HIV. I am sure this discussion was quite extensive, and the discussion about the antiretroviral therapy was also interesting for you and is going to be useful to you for solving your multiple choice question, facing various exams. And I know it's a difficult task which you have undertaken. I'm with you on this task. I wish you good luck. Thank you.